Thank you. And thanks very much, Patrick, for a great talk there. So I have got a very keen interest in not just Alzheimer's, but dementia as a whole. So when I was a child of 7, back in about 1970, I was put in charge of my grandmother who had vascular dementia. So I was actually left to look after her, like they did in the 1970s. And I was capable of keeping her from going outside, because I knew it wasn't safe. And I was capable of telling the postman that my grandmother wasn't all there. And there wasn't anybody else in the house. I wasn't left alone for very long, but it left its mark. So my grandmother, bless her, had no teeth at the age of 70. And she'd had diabetes for a number of years. And then she died. So I don't want that to happen to me and the ones I love. So I've always borne that in mind as a GP. And my father did somewhat better with lifestyle. So my father discovered intermittent fasting before anybody else. And he would actually not eat for 2 weeks. He'd just drink water if he was getting a bit fat. So I think Professor Taylor would like that approach. He was rather fond of sweets called Tic Tacs, unfortunately. So, but he didn't eat them when he was doing his intermittent fasting. And he lived to the age of 80. He still got dementia, but he lived at home till he was 78. So I think it shows that lifestyle did work for him. Yeah. So I've got a few questions, really. And the first one is, I'll just ask the panel generally, when did dementia start? When was it first recognised? Anybody know?
Well, yes, good question. Oh, okay. I don't know the exact year. I'm very bad at history. I got 8%. I love the present and the future. But it was Alois Alzheimer who sort of coined the expression. But I think that what's been happening is the increase in the rate of Alzheimer's has really tracked since the 70s. So we see a very similar pattern to the explosion in diabetes and so on. So it has occurred, before, but it's really seems to be another 21st century escalating disease.
Okay, thank you. I did a quick search before, and I realised that it was actually, but not named, but people expected memories to get worse even in ancient civilizations, apparently. But doctors only started talking about it, I think there was somebody in 1797, and then obviously Alzheimer himself. Yeah, so thank you. I was very interested in your talk about homocysteine, but I'd like to ask Georgia if she sees homocysteine as a cause or an association with dementia.
So that was one of the things I was paying attention to when I was listening to your talk, because I'm not an Alzheimer's expert, I'm a general psychiatrist, and I focus on nutrition and metabolic health. So when I was listening to your talk, I thought, oh my gosh, I need to dig into these studies a little bit more to see if I can sort this out, or maybe just ask you directly, because homocysteine as a molecule within these very complicated pathways that it's involved in the methylation cycle, it's tied to many other nutrients, as you know, including amino acids and B vitamins and antioxidant production and even neurotransmitter production. So really, it feels to me as though there are lots of different things within that pathway that could go wrong that could lead to a raised homocysteine level, including increased oxidative stress, for example, and low B12 being another one. So there are many different pieces to the puzzle. So how do we know that homocysteine itself, the molecule homocysteine, which is accumulating if there's something missing in that very complicated cycle, how do we know that homocysteine is the cause, or could it simply be a marker that something within the cycle, including potentially low B12, is the cause of Alzheimer's? And if so, what's the mechanism that homocysteine, by which homocysteine is damaging the brain?
So, there's a couple of parts to that, and you're quite right. It's a little bit like, on the sort of cancer journey, when we know cancer cells switch to a different form of metabolism. There are many ways that can occur. There are many things that raise homocysteine. But, the original evidence showed that if homocysteine was going up, cognition was going down, and if homocysteine was going down, cognition was going up. But so the critical issue then became, if you do any treatment that lowers homocysteine, do you then get a measurable clinical improvement and or a measurable reduction in brain shrinkage? That's really, if you say, is it causative? To give you an example there. The very excellent meta-analysis. There's now been 30 anti-amyloid drug trials. And as often happens, the companies won't disclose all their data, but they did for 15 of the trials. And I believe it's Dr. Ackley who did a meta-analysis and found that the anti-amyloid drugs do lower amyloid, right? But they don't have what we would call a clinically significant effect. So, in other words, it's a marker, no question. It does something, but it's not actually changing the course of the disease. But where the evidence is in relation to homocysteine is any study that has achieved lowering homocysteine simultaneously achieves either a reduction in clinical dementia rating or a reduction in brain shrinkage. Now, what is the mechanism? There's actually quite a few mechanisms. Number one, and it was kind of on the last chart, the production of NMDA acts as a direct neurotoxin, and that is a function of homocysteine. We also know that homocysteine raises p-tau, the neurofibrillary tangles. So, that's another potential mechanism. And there's a very nice paper, which actually isn't in the list of references that I can give you, that goes through 6, potential mechanisms in relation to the homocysteine. But I think the most obvious one, if you kind of step back and look at the picture, is when we understand that critical neuronal membrane is very specifically phosphorylated fats, largely DHA, some arachidonic acid, which is omega-6. And that combination of phospholipids and the omegas can only occur if you are doing methylation properly. And for those who don't know, if you are not able to do methylation, which is really about the formation of something called SAMe, S-adenosylmethionine, and yes, B6, B12, folate are important, but the liver also has a pathway which involves zinc and trimethylglycine. There's also a sink that involves glutathione, so there are lots of other things going on. But basically, homocysteine goes up as an indicator that you are not able to do methylation. You are not able to process the amino acid methionine into S-adenosylmethionine, which, by the way, is what turns genes on or off. So homocysteine is a functional test. In the same way that I love HbA1c, it's kind of such a good marker of whether your glucose resilience is is going out of balance. So homocysteine is a functional test, and I do believe, as shown in that slide, that the evidence is strong enough to imply strong causality.
Okay, so thanks very much. I want to bring it back now to the level of, what we can do diet-wise, because that's what everybody here would like to know. And just thinking about your talk, Ben, about insulin resistance, I presume all these people have got insulin resistance.
Well, not necessarily.
Sorry, I was just wondering about Ben asking. Yeah, see what Ben, let's hear what Ben has to say about it.
Yeah, right. I can't speak to the statistics of how many people with Alzheimer's have confirmed insulin resistance. I suspect the number is higher than has been confirmed, simply because it is a problem that is so often undiagnosed because we look at the wrong marker. My view as a mitochondrial/endocrine devoted scientist is looking at the tragedy of the scenario that we find ourselves in. Namely, we have people that are hyperinsulinemic and insulin resistant. Well, the hippocampus is one of the parts of the brain that has these insulin-dependent glucose transporters. And as I alluded to in my talk, not every cell of the body needs insulin in order to pull in glucose. Indeed, most don't need insulin. There's essentially an open door for glucose to come in at any moment. But the muscle, fat cells, heart tissue, all do have an insulin-dependent glucose transporter, but so too does parts of the brain, including hippocampus, which is relevant with Alzheimer's disease and among some other spots. But the particular tragedy is twofold. Namely, the person is insulin resistant, including the brain. Stephen Cunnane, whom Patrick referred to, has shown this, and others have too, determining a true reduced response to insulin and reduced glucose uptake because of it in the brain. But at the same, so on one hand, the brain is lacking the ability to pull in glucose, which just to pause, my next one is particularly tragic, right? Because the body is flush with glucose. It's like this metabolic version of Samuel Taylor Coleridge's Rime of the Ancient Mariner, where he says, water, water everywhere, nor any drop to drink. The brain is saying glucose, glucose everywhere, but I can't get it. I can't use it, but the body is swimming in a sea of glucose. So the brain is starved for glucose because it's insulin resistant, and while it is crying out for the only other fuel it can use, namely ketones, the high insulin is preventing the liver from making the ketones in the first place. And this is the relevance of the ketone, which itself is a product of the body burning a lot of fat, well, the liver burning a lot of fat, was very influential to me with Stephen Cunnane's work in Quebec at Sherbrooke University, where he has this cheeky line where he refers to the survival of the fattest. Are you familiar with Stephen Cunnane's work, you guys? His idea does touch on this kind of shore-based evolution, one among many theories of evolution, which is that we are unique among land-based mammals because we are the only mammal on land born obese. And we are. Compare a human to any other animal on land, and we're obese. We look at a cow and think a cow is fat, not compared to us. They have a big belly because they're ruminants. But we are born very fat, and we're born with very hungry brains. And that baby fat is so helpful because it helps the baby burn a lot of fat to be in an almost constant state of ketosis to fuel this explosive brain growth. Now, I've gone too long here, but I would just say...
That makes me think of something very interesting.
Maybe to sum that
it's
sentiment
how
up.
Fat 3-year-olds often don't eat any food.
Yeah.
They just go around, they're really picky, their parents worry about them not eating anything, but I guess they're living off their body fat.
Right.
Yeah.
Well, believe me, it is difficult to get kids to eat what you want them to. I know that, certainly. But again, the brain becomes insulin resistant, depriving the brain of its glucose. And at the same time, this is a body that is not allowing the liver to make ketones because the high insulin. And collectively, that's a perfect metabolic storm, and the brain is left to pick up the pieces.
Yes, please do, just briefly.
It sort of adds on. And I can sort of do this in the example of Nodge, the case history. So his HbA1c was 5.3. He may or may not be insulin resistant. We don't know. It wasn't tested. But he certainly... Exactly. So that's all we know about him. So that's the first point. The second point is that actually what Stephen Cunnane's research showed, and he excluded diabetes in his study on those with mild cognitive impairment, he gave C8 oil. It's that portion of MCT that the liver uses so effectively to make ketones, and showed not only a 230% increase in energy derived from ketones in the brain, but also improvement in cognitive function. So, and Nodge, found the same thing. So he's been having C8 oil, he's been doing 5 days a month ketogenic. He notices feeling better when he does that. If he went to dinner with some friends and they fed him carbs, and he noticed feeling worse. So the point I'm making here is you don't even need to be diabetic if someone's in a cognitive impaired state to get a benefit from anything that delivers ketones to the brain. I think the big problem that we have with so many diseases, and Alzheimer's is a perfect example, is there are plenty of people who develop Alzheimer's who don't have raised homocysteine. And there's plenty of people who develop Alzheimer's who probably don't have insulin resistance. So we're trying to, It's a very major factor
Well,
for
can
sure.
can I
Yeah.
stop you there and just say
Yeah.
that it's very interesting that Food for the Brain tackles about 8 parameters.
Yeah.
But when I've read the work of Dale Bredesen, and it's obviously a few years old now, but he was looking at about 36 parameters. So there are obviously a lot of things going on that are apart, well outside, what we've been talking about so far. Just a matter of interest, Bob, you're a GP. So what do you say to people with, say, early dementia, mild cognitive impairment, or their families about their diet? This one there.
I think it's the same sort of general advice. Before we can refer people to dementia clinic to access support, there are some baseline blood tests we do. So rule out diabetes, B12 folate level, vitamin D I do most of the time now. And wherever there's obvious supplementation that needs to be taken, then that advice is there. I'm always going on about low carb. The problem with GPs is they've got 10 minutes to get across what they need to. So I see whether they're receptive or glazing over. And if they're not glazing over, I'll go into a bit more detail and say, come back and we can talk about this and maybe do a 2-day food diary before you see me next time. But what I'd like to know, again, the focus is always on big pharma and prescribing. How effective are these anticholinesterase drugs? Because from what I did read years ago, they only improve your cognitive parameters by 1 or 2%. If taken, at best, they might slow down the decline. But from what I've heard today, it's totally the wrong focus, and that's where all our attention is.
Mm-hmm. Well, it does. I mean, it does feel to me as if we're barking up the wrong tree with these drugs, because we're not addressing the root causes. What about you, Georgia? Do you want to say anything more about other parameters? Because those 8 are, I'm sure they're really important, and that's come up in the research that I've been doing about dementia over and again. But are there any other major ones that we should highlight here?
Yeah, so just picking up on what they were both Ben and Patrick were saying, one is that, at least according to one study I've seen, 80% of people with Alzheimer's had insulin resistance. It's not tested enough, but that's about twice what you would expect for that age-matched population. So it's about a 2x risk factor, so that's considered significant. But beyond that, insulin resistance itself has so many downstream effects. So if you have insulin resistance, there are a lot of things that are going wrong that will cause other things to go wrong. And so for example, as Ben was saying, when the brain becomes insulin resistant, the glucose can still waltz in, no questions asked, to most of the cells in the brain, but it can't. The cells can't use the glucose for anything, to create energy or to create molecules, all of the little parts that all the cells need in order to keep functioning well, or to repair themselves. The cells can't use glucose for anything without enough insulin. So if you have a high glucose, low insulin brain, which is what happens to most of us as we're getting older, if we're becoming insulin resistant, which is happening to most of us now, what we have is kind of a 1-2 punch for the brain. We've got low brain insulin and high brain glucose, because the higher your blood glucose, the higher your brain glucose. So not only do you not have enough insulin to use the glucose, the high glucose levels are actively damaging the brain. They're causing all kinds of stickiness inside the brain, caramelizing all of your molecules, and causing all kinds of inflammation and oxidative stress, which will also throw off your homocysteine levels and poke holes in your blood-brain barrier, and so on, and shrink your hippocampus. So, and a lot of the treatments we use, this is coming back to another thing that Ben had said earlier, metformin is a very commonly used medication in people with insulin resistance as they're getting older, and that is a medication which impairs our ability to utilize B12. And so all of these things are connected, and as Dr. Dale Bredesen says, I think he's in his books, and I've read them, he's a neurologist with lots of experience, specifically with Alzheimer's. He says, so there's at least 36 holes in the roof, lots of different things you can target. But most of those things, not all, many of those things are correctable with diet. So some of these things are vitamin deficiencies, sometimes correctable with diet if you're healthy enough to absorb those vitamins, but also insulin resistance, high glucose levels, low insulin levels, and a ketogenic diet is a cornerstone of his treatments, regardless of what else he prescribes. His protocols are very individualized, but all of them include a recommendation for a ketogenic diet. So you want to always start with the fundamentals, which is good nutrition, nourish the brain, protect the brain, energize the brain, nourish the brain with proper food, energize the brain by keeping your glucose and insulin levels in a healthy range, and protect the brain by not eating things that are going to damage the brain from the inside out.
Oh, that's a very good answer. Thank you very much. Now, I want to just think in terms of, our collaborative nature. So obviously 2 of you on the stage are from the US and 2 from the UK. And you've got experience of a very different health system to ours. And we've, as a collaborative organisation, we've done work in reversing diabetes that we heard about earlier and other things. But if we were going to take up the mantle of reversing Alzheimer's and dementia and start up pilot programs, thinking in terms of collaboration with our health authorities, this is really a question for the 4 of you. How would we go about that in setting up something at the moment? Or maybe Patrick might start. I mean, you might have ideas with your charity, for instance.
No, absolutely. A couple of things there. And also, I'm totally focused on a low glycemic load, getting the carbs down, ketones and all that sort of stuff. But statistically, 2 in 5 people over 60 have low serum B12. And around half have raised homocysteine. And this is not something that can be dealt with just by diet, and that's very important. Now, right now in the UK, almost all GPs do not have access to being able to get a homocysteine test. And there's no logical reason for that. It's a very cheap, simple test that any hospital lab could do tomorrow. And also, if you have a dementia patient and you test their serum B12 and it is low, you cannot, under guidelines, actually prescribe them B12. You can only prescribe B12 to somebody who's been diagnosed with pernicious anemia. So if you wished to follow this stream and actually take action, you can't. This is the situation here in the UK. So in a sense, there are 2 direct things that need to happen within the UK health system. One is the ability to measure homocysteine. That is absolutely critical. The evidence, it's a bit like not being able to measure HbA1c. I mean, it's so critical. And the second is to allow doctors to prescribe B12 to people with mild cognitive impairment. So that's that. Of course, what I would like, and I think that this is, we all know it, but we don't quite talk about it, is we know these diseases that we're treating are systems-based diseases. It's not just one thing, even if sugar and insulin resistance is a massive, piece of the equation. It's not just one thing. So what we're hoping to do with our digital health behavior intervention is to find a way to motivate and encourage individuals to actually make changes. I mean, that's the purpose of it. So I sincerely hope that we can get to the end of 2024 with data on 1 million people. And I'll tell you 2 things that are terribly interesting. One is that we have a friend, a professor of business studies at Harvard, and he's going to get us a pro bono, one of the top AI machine learning organizations, so we can look at all these factors and find out what is the combination of behaviors, diet and lifestyle, that means lowest risk and means highest risk. And then Dr. Christina Curtis and her brilliant team, applied behavior research team at UCL, they're going to come in. So that's the what combination of factors. But then how do you make those changes? So she's joined our group to come in and actually look at how do we actually get people to eat less carbs, to exercise, to increase their intake of omega-3 and so on. The how is incredibly important. My personal view, I've been in this field for a long time, started the Institute for Optimum Nutrition with Linus Pauling, trained several thousand nutritional therapists who I would hope would work with GPs, is to really change the paradigm globally. It has to be digital health behavior change. That's what we are focusing on, how to change behavior on a mass scale. The issue with Bredesen is that when you've got 30 factors and the tests alone cost you $4,000, it becomes very exclusive. While what I think we are all about are simple changes that people can do whether they're rich or poor. And the issue is, how do we motivate, educate, build the trust for that to really happen? I want to tell you right now, the official spend on the anti-amyloid drugs is $50 billion. The actual spend is $100 billion. And we cannot, I mean, Professor Peter Garrett and David Smith have a perfectly designed omega-3 and B vitamin study. I mean, it's obvious. And it's £3 million. And for the last 5 years, they've been unable to get that study funded. You know, that's the way it works. So we need to get funding to really look at prevention. And the way to do that, by the way, is simply to say to our government agencies, in this case, the government have pledged $160 million a year for the dementia moonshot, is to say if half of the risk is preventable, we need to legislate that half of your dementia research money is spent on prevention research.
That sounds like a very good idea. Thank you. So we're running out of time now, and we've got one more question, which has come up a couple of times, which is the link between statins and dementia. You know, so I don't know if you know anything about that, Georgia, or... Yeah, the link between statins and dementia. You know, there have been moves to give dementia patients statins, and with the idea they might be helpful. And also, there's been there is noise around that maybe statins might be causative with dementia as well.
I'll just briefly start it then. I would be very, very surprised to hear that it's helpful. There have been some longitudinal studies. I think that was the Daily Mail one.
No, sorry, I shouldn't say that. It was just in the media.
There have been some prospective studies that have looked at cholesterol levels and dementia risk, finding that the higher the cholesterol, the lower risk of dementia. And that could be for myriad reasons. Part of this could be that if you are attacking cholesterol, you are unwittingly attacking all of its products, including those involved in the electron transport system of the mitochondria, where ubiquinone is a critical linchpin electron carrier from complexes 1 and 2 to complex 3. And if you can't carry the electrons, you've stopped the electron transport system essentially at complex 1, which is going to give birth to an enormous amount of reactive oxygen species or oxidative stress. So that's the prospective studies. There's a study in the U.S. and a study in China that I'm thinking of when I'm mentioning that. So again, evidence showing that if cholesterol goes ever lower, Alzheimer's dementia risk goes ever higher, and vice versa. So it doesn't seem prudent to declare war on cholesterol, which is a molecule of life. Moreover, statins, especially in women who suffer more from Alzheimer's disease risk anyway, if a woman is prescribed statins as a primary prevention, her risk of developing Alzheimer's disease is developing type 2 diabetes is 50% higher. Once again, this could be because you are damaging the mitochondria, and that can manifest with an insulin resistance due to the oxidative stress. And of course, type 2 diabetes is a primary risk factor for Alzheimer's disease. So the idea of prescribing a statin for I can't imagine it would ever be prescribed for Alzheimer's. That would be laughable. But if it were prescribed for a heart disease risk, it still may be laughable. Although the evidence, that would certainly be a very hard-fought philosophical battle. But the evidence that it's the suggestion that the few extra days of life you get, as Aseem Malhotra would have cited here with a statin, it won't help Alzheimer's and likely would make it worse. And even independent of the mitochondria, the brain is so fat, it's so loaded with cholesterol that you are depriving the brain of its very substance.
Well, thank you very much.
I was just going to say, in one study of biomarkers, the two most predictive biomarkers for dementia was raised homocysteine and cholesterol below 4.
Right. Well, thank you very much. That's a very good note to finish on. If anybody else has got any questions, and there were a lot of questions on the live chat, I'm sure people will stick around for a little while afterwards, and you can come down and ask them. So now over to Sam.
Just one from Heather Bain. Is Heather Bain here? Yes. Oh, there you go. Yeah, no. So a very kind of practical question. How do I educate my mother's care home to change their catering choices? Cake, biscuits and sandwiches as a staple.
So I don't know if any of you have got any experience of that, trying to change a care home diet. I've had more experience with people asking how to change a nursery diet. But Bob, have you got any experience of that?
No, I think the best you can do is encourage relatives to take decent food in whenever you go on visit. That's probably going to... The bottom line for care homes is cheap and filling, temporarily filling. That's what it boils down to. If you look at who runs care homes, increasingly it's private equity, and that's all about extracting profit. In terms of pressure on policymakers, the more of the public who are aware that our healthcare system is being run for the benefit of drug companies and other people, not us, then only then we can put pressure on them to do the right thing. So spreading awareness, and in terms of anecdotes about my patients on statins who are old, if they're developing dementia or they have other issues like poor sleep, the first thing I do is stop the statin. If they come in with muscle pain, first thing I do is stop the statin. And there's a desert of informed consent, because as soon as you lay out, my GP registrar, GP trainee did a survey of people who weren't on statins, who were diabetics, but what he did was presented them with the evidence, and 70% said, we don't want the statin. Tell us about the lifestyle.
I think that's very true. So, I've got a dilemma at the moment. I've got an uncle in hospital who's got spinal abscess, and his room is just full of biscuits and cakes, and he doesn't really eat he doesn't eat them very often, to be honest. I don't think he finds them very nice. But where do you start? And I think you just have to start with, this isn't going to be helping your infection. You're going to be in hospital longer. If it's back to a nursing home, really, I suppose it's getting involved with the management. I mean, in terms of collaboration, I was approached by a dementia care provider who wanted to come along to our conference. And I think maybe we could have collaboration with dementia care providers, whether they're NHS or private, because that's the reality of what we're dealing with at the moment. And work with them on diet. Maybe we could do a pilot with them in terms of, say, Patrick, you getting in with your app to the staff, because staff can sabotage things. The relatives may not be taking in cakes and biscuits, but the staff can say, oh, go on, have a biscuit. So there's something for me about when we have our pilot project to do with dementia and preventing dementia, that we collaborate with providers and we'll have another strand to our health journey in the UK. So thank you very much, everybody. It's been a long day.